Good morning, everybody. Thank you for joining us for this webinar, one of our early bird debates in partnership with Merck Sharp and Dumb. My name is Dwayne Schultes. I'm the Managing Director of Vital Transformation. And today we're going to be discussing who pays for hope treating cancer early. And again, thank you very much for joining us today. Before we begin officially, just a couple things here for house cleaning. If you're having trouble with your audio and you want to switch to the phone, please click the little button next to the mute. This menu will pop up and you can switch to the phone. And as well, we love having questions from you. We love having your participation. Please use the question bar and submit a question, and we will happily answer your question as they come in, and I will distribute them to the panel. And again, thank you very much for your participation. So there has been progress with new cancer treatments where we see mortality rates decreasing compared to incidence, but many new oncology drugs are studied only in the late metastatic stage of the disease. The challenge then is, should we use these new drugs at an earlier stage of treatment? The newest best drugs are often used when the outlook for patients is the most poor. Should we investigate their use when the cancer can actually be removed earlier with surgery or often with standard chemotherapy? This would be as an adjuvant treatment, serving to aid other treatments to contribute to an earlier cure. Does earlier treatment even work? Earlier use will often rely on other endpoints than overall survival. Some payers may challenge the value of the drug in the study if we use these treatments earlier. Would payers pay for hope? Where does the patient sit in this decision? And I'm extremely pleased to be joined by two exceptional speakers today. So I'd like to introduce you first to Bettina from the Melanoma Patient Network. Good morning, Bettina. How are you?
Good morning. Lovely to be here.
Thank you, Bettina, as well as Anna Buzic from MEDEV, UNETA, the Mechanism of Coordinated Access to Orphan Therapies, as well as many other organizations. Good morning, Anna. How are you?
Good morning. Thank you. And thank you for the invitation.
Well, it's our pleasure. So to begin, Bettina, from the patient perspective, if we're starting to use treatments earlier, what sort of information do you want in order to make a treatment decision for a neoadjuvant or an earlier setting beside the metastatic? Where do we start using these newer treatments?
Well, thanks for that, Dwayne. And that's obviously for us in melanoma a very relevant question, because we have seen overall survival improve from 5% at 5 years in the time when my husband was diagnosed to 50% in 5 years. And that happened in like 5 years again. So we have seen this dramatic increase in survival in the stage 4 setting. At the same time, we learned that the earlier you treat, the lower the tumor burden, the better the outcome. And then obviously the next step is, how early can we move it to even improve on these 50% survival? Because in the end, that still means that 1 out of 2 is going to die, and that's still not good enough. So we've had this discussion for a considerable amount of time. And so I had time to think about it. I think what we have to understand is that this scenario or the setting between a stage 4 setting and an adjuvant setting is completely different, and that we have to be specific when it comes to the discussion. If you have received a stage 4 diagnosis, you know that if you do not treat it, you are most likely going to die. So in a way, there is very limited uncertainty. You know you have to treat. That is not true if you move, like, let's say, into stage 3 or even earlier, because you have had, let's say, an intervention like surgery, you have removed the tumor, and some patients will never ever progress to stage 4. If you then now start using a treatment, you might optimize the chances of not progressing, but at the same time, there will be, for example, side effects. There is the burden of treatment, so you'll have to go to hospital regularly. You get constantly reminded of the disease. So all of a sudden, the kind of trade-offs are different. And we have seen differences in our population. So we will have patients who will say, I take anything in order to prevent it from coming back. And others say, you know what, I might never be the one who progresses anyway, so I'm going to risk it. So I believe when we switch from stage 4 to earlier settings, what changes is the trade-off between benefit and risk. So side effects are becoming way more important, and also long-term side effects, because these people will be around for a long time. I mean, that's the purpose of the entire exercise, as well as personal patient preferences. So the discussion, we have to restart the discussion around these therapies, actually. And though it is the same product, because the setting is so different, I think this discussion has to change. And I would like to stop for here now to and maybe take it up later on.
Yeah, and again, I think one of the other questions then is how do we see the payer in this? Because we're already seeing very long lag times, even at metastatic stages, over 500 days in France, for example, to certify some cancer treatments. So Bettina, from your perspective, how should the patient work with the payer, or what sort of evidence should you be providing? What sort of feedback from your perspective? And then Anna, I'm going to come back to you with this as well. So how do you think the payer fits into this then, Bettina?
So, well, I think the problem that everyone has, there's not just the payer, but also the patient, is that we will only know in many, many years down the line what is really going to be better. And maybe we will never really truly find out because we're getting more and more treatment. So the landscape is evolving and we're always comparing apples and pears. At the same time, knowing that there is something that might keep you alive and not getting it is probably one of the hardest things you can experience as a cancer patient. So from my own experience, I mean, we were in our early 30s, and then all of a sudden you get a stage 4 diagnosis. And it is not just stage 4, just a cancer diagnosis affects your life profoundly. And then being told there's something that could save you, but you're not going to get it for a price, whatever, is something like adding, like, it's like society failing you. We all contribute to our societies, especially here in Europe, and we expect society to take care of us when we need it. And not receiving that care is brutal in that way. At the same time, we want to be sure that it's really working, because you don't want to induce toxicity and you don't want to go to hospital without it working. So I'm a big, and you know that, I mean, I'm a big favorite of like being pragmatic about it and testing and learning while we go along. So as a patient, you cannot wait 20 years until we know, because by that time you might be dead. So you need a decision, something pragmatic today. At the same point, just doing something in the vague hope that is also not good enough, neither for the patient nor for society, because we cannot, I mean, just think about it. Just giving these things out, because we're not talking sugar pills, right? You're not giving people an exercise regime where you think, well, the worst that could happen is maybe some joint sprain. But this is dangerous stuff. So I think we have to be realistic about this, how this goes. I know this is not an easy answer. I do think that pragmatism is the name of the game, and we have to be specific, because it obviously very much depends on what you want to use, for example, in the adjuvant setting. It makes a difference whether it's chemo, immune therapy, or targeted therapy. So we need a solution for each of them.
Sure. Now, Anna, from your perspective as a former HTA and payer, and obviously very involved in these decisions, what sort of level of certainty do you need when you're making a funding decision? I mean, how do we actually deal with this from an evidence standpoint?
Well, this is really a very difficult question, and the standard answer is it depends on case by case.
Sure.
So if there already is a treatment available, this raises the bar for the product on the one hand, because the evidence that we need is to show that the new product is at least as good as the comparator. This is a crucial difference to the licensing situation, where the emphasis is on the benefit-risk ratio of the product itself. So when you're talking comparative effectiveness, on the one hand, it's more difficult for a company to show at least equivalence, but on the other hand, if the product is somewhat similar, then there is already a suspicion of efficacy, so that's easier. If we're talking about a new treatment where there was none before, then the situation is more akin to the marketing authorization, but you still need robust evidence that the new therapy is a good use of resources. So you need evidence for making a money decision.
Sure.
So you look at the effect size and the certainty, but ultimately it's a value judgment. It can be a very straightforward value judgment if you have a robust effect on a patient-relevant clinical endpoint. Then as a payer, all you have to do is figure out if you can afford it. There used to be a greater willingness to accept more uncertainty in oncology, and this is still the case for ultra-orphan indications, for example. But how much more uncertainty? Again, this is a value judgment, and it's ultimately influenced by the need for treatment, the unmet need, and the feasibility of generating evidence on mortality, morbidity, and quality of life. And this is really challenging. We had some talks before, and it's really challenging for the quality of life, for example. Morbidity may be more straightforward. So the question is, can payers expect further evidence after making a reimbursement decision, even if this is only provisional? Where will this evidence come from, and what can be done with that evidence? Can you really use that evidence to make a further decision, for example, to rescind reimbursement? So it's about the relationship between certainty of evidence, the effect size, and the price. And this should be straightforward, but it actually isn't. So there are several studies criticizing the low level of evidence for new and very expensive cancer drugs. One proposed way to remedy this is coverage with evidence development, meaning that marketing, making reimbursement decisions and contingent on a certain price and on providing evidence. This is a good way to agree to very intransparent rebates. And it also may be scientifically sound. However, it's quite difficult to administer in practice. So I think everybody's working on this type of issue, how to get this conditional reimbursement with evidence generation, and what are going to do with the evidence. There is some progress being made there, but I think it's still early days and kind of slow.
Yeah, and obviously one of the key things there is we're moving from overall survival to a surrogate endpoint like progression-free survival by definition, if we're moving it further up. I mean, from your colleagues, you and your colleagues' perspective, would a PFS work? I mean, is that going to be viable to you? I mean, obviously in something like melanoma, before we would have taken it because the alternative is, we know what the outcome is eventually. It's not good. So, and certainly you could probably say that with some of the more advanced leukemias as well. I mean, what's your feeling on something like substituting a PFS for overall survival?
I usually start my presentations on payers with a slide on herding cats.
Okay.
That's good.
So it's fun working with so it's always consensus is what you're saying, right?
Yeah. So there isn't. Sometimes it also depends on the type of tumor. Bettina probably knows more about this than I do, but there are tumor types where PFS is a pretty good surrogate for overall survival, and in some tumors it actually isn't. So there isn't a general consensus on that, because it really depends on the tumor, for one thing. And on the other hand, there might be other things that might be more suitable than PFS, like maybe hospitalizations. Maybe we can look at some of the trials that were done with breast cancer and the aromatase inhibitors. You got evidence there, so
Sure.
maybe we can use some of those lessons.
Bettina, from the patient perspective,
Yeah, well, I mean,
what do you think about OS versus PFS in some of these debates? What's your perspective on this?
Well, so there's quite a bit to sink my teeth into. So first one, I would like to touch upon what Anna said on value judgment.
Sure, please.
I think that is a super, 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 super important part of this discussion, and something that we often overlook, because we always go like, well, it's all about, we all want to survive. Yeah, right. Of course we want to survive. But I think it's a bit more, we have to look closer at what truly matters. And Anna actually already said that maybe we have to think about newer endpoints. So first, one thing on surrogate endpoints. When we talk about the adjuvant setting, we actually don't talk about PFS, because that's progression-free survival. So that is until the disease starts growing again. So we talk about disease-free survival. And well, while you might think that DFS, PFS, what's the difference, one letter? I actually think that conceptually, and from a patient perspective, it's a huge difference. Because disease-free survival means you don't have cancer. You might be in treatment, but you actually don't have cancer. I mean, NED is no evidence of a disease, is one of the first things that any cancer patient learns. And people understand quite early on that cure is a big, big, big thing to hope for, but NED is close to it. So being NED, that is like something you really aim for. So having no disease in your body is huge. So to take it as some kind of, I always say, margarine instead of butter setting, I don't think is appropriate, because it does not capture what it means to a person not to have cancer. just from the apart from the psychological effect, which I think is still important, a cancer can also mean, a cancer is not just sitting there not doing anything to you. Cancer can cause enormous pain depending on where it sits. I'm in melanoma. Melanoma metastasizes everywhere. For anyone who has difficulty, just imagine a tumor growing in your groin area. I think that doesn't require much explanation. It can also destroy organ function. Then you have to deal with that. So a tumor it's not just there, it also causes pain and trouble. So just not having disease important, that's one thing. Then the relationship between that surrogate and the endpoint is of course critical, and Anna already alluded to it. We have always, and I've heard it so many times, I'm getting tired of it, that PFS is overestimating overall survival benefit. That might have been true for chemotherapy, but if you look actually at the data from immune therapy, it's not true. It is so that PFS, for example, underestimates overall survival. We saw this quite impressively in our early trials, that the PFS didn't look very impressive in the advanced setting, but our people wouldn't die. Hey, I take that. So I think this relationship is something we have to discuss. From a regulatory perspective, they're not so worried about it. It's the HTAs and the payers that would like to have a value of 1.73 or whatever it might be in the relationship. And I think that's something that is often lacking in terms of specificity in the discussion. So we have to think about how the two, so the value of the surrogate, the margarine and such, because I would argue that it's not just margarine, that there is value in there, and the relationship to the final thing where we claim that this is the end game. It's getting much more complicated if you look into quality of life and the issues in how to measure this appropriately. We've been hating the tools that we've been using in melanoma because the feedback we were getting from patients was that it wasn't relevant to them. So if we measure something that's not relevant to the person concerned, we should not be surprised that the outcome or what we believe to know is not relevant either. So it's not easy to measure. So I think that's a big issue around that. And then visits to the hospital. I think burden of treatment is something we often don't talk about. But I don't think it's a coincidence that people joining clinical trials are often self-employed. You just take your computer, you work in hospital. I've had people turning down trial participation because they could not afford to spend a day in hospital. So that's something I think, and maybe COVID can help us to get to rethink how we reduce the burden of treatment on the patient. And I actually think that's a valid endpoint as well, because it has so many ramifications. So I think the discussion needs more detail and more kind of color in it. It has to be specific, as Anna said earlier on, in order to accurately capture what truly matters for us. And before you cut me off, one point that we often don't talk about is we say, oh, DFS, it's just another year. If you live in a fast-paced environment where innovations are coming through like this, as we have seen in melanoma in the last few years, postponing the time point when the disease comes back, even by a little bit, can make a huge difference simply because new therapies will have become available. So you buy yourself the time in order to respond to something that hasn't been invented yet. And that's something that's very hard to measure because we take a speculation on the future, because we don't know what's going to come. But I can tell you from a personal perspective, that's a huge thing. So you buy the time until the next trial opens, the next treatment gets reimbursed, the next option comes along. And I think we somehow, in an environment, we should take this into account. So postponing the progression in order to access something new. I stop there before you me.
Thank you, Bettina. And I try to cut you off delicately, so please. Just again, we've got 10 minutes left, folks, and we do like to try and incorporate your questions. Haven't any questions come in yet, even though there's quite a lot of you online. Please use the question bar, submit your question, and we'll try to get it in here in the last 10 minutes or so. Anna, I want to pick up on some of the things Bettina said there, and one is around the evidence for some of these new pathways and some, bringing these things forward. Do we have any functional real-world evidence models that can do comparative effectiveness that sort of has a baseline of agreement right now? Do we have any of these tools? Or are there some that you've seen that can work given your work that you're doing now with orphan drugs, et cetera? Is there something that you think we should be developing?
Well, it would have been easy if you asked me what didn't work.
Okay, all right, what doesn't work then? Okay.
There are some things that could work and some things that worked well in some countries. Bettina mentioned COVID, the recovery trials, everybody's very enthusiastic about the way the recovery trials work. So I think you can have some pragmatic trials along those bases. And if you look at very simple endpoints, you can do maybe a pragmatic RCT. But I think what we need to think about is the way we look at this kind of adjuvant or neoadjuvant therapy. This is taking cancer treatment from an acute treatment to something that's a chronic treatment. And the evidence requirements for chronic treatment, or if you want preventive treatment, are quite different from, you know, the classical evidence requirements for cancer treatments. It's more like for cardiovascular disease. And your sponsor is not going to be very happy about it, but this will also affect the price of the treatment. So that's what I would like to
just
bring this in.
Go ahead, Anna. I'm sorry. Yeah, one other thing I'd like to touch on that Bettina brought in, which is, you know, some of the quality of life assessment. Because, you know, for example, if we look at some of the new immuno-oncology treatments, you know, they work very well, but so does bone marrow transplant. Although bone marrow transplant is hugely invasive, graft versus host disease, all sorts of complications. You know, they require very labor intensive. You require a second person for a donation. You know, some of these treatments themselves are just more efficient, even though they're more expensive, and they have benefits over on a quality of life perspective. Do we need better metrics to measure that? Is that something that's lacking? Because if you look at them head to head, they work well, but, you know, bone marrow transplants are, you know, boy, they can be really awful if they don't work.
But that's not adjuvant, right?
And that was for you, Anna. Yeah, okay.
Yes, I think Bettina could already mentioned that. I already participated as a person in one of those quality of life assessments, and it's really difficult. It's horrible. It depends on the situation where you're in. I mean, if your coffee didn't taste well this morning, you're going to tick a different box on the VAS than when you've had when you got up well in the morning. So it's very difficult, and I think they're way not sophisticated enough.
Bettina, what would you be looking for from an improved quality of life assessment?
First, I would like to answer the question that you asked to Anna, because I think for an example, what works and what the caveats are. So, for example, the Dutch Melanoma Treatment Registry is also an access under evidence generation scheme. Something we have learned from this is that you can also by accident learn. I mean, I'm always thinking, like, you know, if you do a germline sequencing, you might discover things you didn't expect. The Dutch Melanoma Treatment Registry was just like that. So they had some unexpected findings they didn't want to find, which jeopardized the entire thing. So I think if we want to do this properly, we have to rethink how we generate evidence. It has to be systematic, and we have to keep partial interest out of the system because they can jeopardize everything. So it requires thinking and a consistent approach, not one product at a time, a bit here, a bit there, but something that a country has to put in place. So that would be my answer to that. And there are some questions coming in, which I know that we have to be a bit mindful of time. When it comes to
we're running out of time. Yeah.
We can just talk a bit faster, right? When it comes to quality of life, I fully agree with Anna. We've been trying to look into it. We've actually did a study together with ZIN, so the Dutch HDAs, and we did a free text analysis just to capture on a high level what people really valued. And it is quite humbling what came out. What people want, I mean, what came out, the word that came out was family. So if you went digging deeper, is what people want is normality. And it's really hard to measure how far you are away from your normal imagined life, because what you imagine is probably better than what you would be getting in reality. So just to build on what Anna said, this is really difficult, both in terms of what we measure, but also how we measure, because we don't want to measure coffee quality, while that is a very interesting topic. So to get to the questions, which one? Take your pick, Dwayne. It's just like they're all very good, actually.
They're all good. I mean, Alexander Rottinger's is quite short, so I'll start there, but it'll probably take the next 3 hours, and we've only got 5 minutes. So Alexander's question here is, how can we align price and evidence? Very simple, right? So how do we align price and evidence right now with the tools we have, or what tools do we need? Anna, starting with you, how do we align it practically? What do we need? Let's put it this way, from a status standpoint, what do we need to align price and evidence? What's lacking?
Well, there are several tools and instruments and methodologies to compare price to evidence, like, you know, value-based pricing, but that doesn't work. So aligning price and evidence is not enough. You have to look at the bigger context. You have to look at the budget impact. You have to look at affordability, and you also have to look at the alternatives. I mean, if all the health system would pay for all the things that are considered cost effective, they would go bankrupt. So you always have to prioritize. And again, it's a judgment value. You can have systems like, you know, NICE, where you say, okay, you're going to pay 20,000 pounds or 20 or 30,000 euros or whatever for one quality. That doesn't work for orphan drugs, and it doesn't really work for these cancer treatments. So I think you have to look at it in a broader way.
Bettina, from your perspective, what tools do we need to align the evidence requirement?
So now this is a typical patient advocate chickening out answer, because someone actually said to me, your job is not to have the answers. Your job is to ask the tricky questions. And I will make shamelessly use of that. So it's very easy to get trapped in technical details. And should we add this factor, and should we multiply it by 1.3 or maybe 1.5? And how does that now impact? My job is to think about the human impact. What's the outcome in the end? Because you can all totally say from a cost effectiveness perspective, there's no value, but it is real people who die in the end. And I mean, my husband died in a room downstairs from here. So I have a very acute feeling what it is like. And there will always be people who suffer from any decision we're making, either way or the other. And I think our ambition as society is to find a solution to minimize true suffering. And that's not about a point of 1.3. So I think what I'm after is that how do we find a solution to this conundrum? And I think at COVID now, sorry to come back to it, we had said we're not going to discuss COVID for a change. But I do believe it has shown us that that we as systems have to make decisions. If we want a product available for everyone, we might have to rethink how we pay for the entire thing. We will have to rethink our incentive system. So I don't think it is about, you know, a multiplier of 1.3 or whether we incorporate this or that. I think we're getting pushed more and more to having to really rethink how we do drug development, how we pay for products, because our societies will not accept that we will have no access to innovation. And we're pushing towards already that. Our citizens will not be happy to say, you know, someone else is having it and we don't have it. You think that any politician will get elected by that? At the same time, we can't just print money. So I think we're in for a system change, and COVID has pushed us. So I think this is really like, you know, we've been discussing this around and around for some time, but I think it's time to rethink the system bigger than just small technical details.
Is the UK Cancer Drugs Fund something where you fund it while you gather evidence, you fund a new treatment? Is that potentially a solution, Bettina?
Well, you know, I've just told you I'm not the one for the solutions, but I do like the pragmatism in there, because it is a way. It's not a perfect construct. There is no such a thing as perfect in this world, but having this mixture of access while learning. We don't want to keep doing stuff that's not working. I think is really helpful. And it's like you put a time window on this. We should stop doing things that are not working. So having some construct, whether this is now the perfect one and should be copied, is besides the picture. But I like this access under evidence generation. From a patient perspective, having access now is important, because you might not be alive by the time they finally reach the decision. So the time is important. At the same time, if they find out it's not working, you might as well stop the treatment. And that's important to know too. So I like pragmatic.
So Anna, from your perspective then, with the UK cancer, to answer this conundrum, this access under evidence issue, would something like the UK Cancer Drugs Fund done on more of a European level, would that be something that might work?
Well, I actually have a little bit of experience with something like that in Austria, because there is a method whereby clinical trials can be funded by payers. There are a lot of rules around that. One of the most important being that if the question will lead to an increase of the the number of patients or the time that patients are getting a drug, then that's a financial consideration. So yes, it can work, but the devil is always, as always, in the details.
Yeah.
And one of the things that payers think about when they're thinking about this is, what's the price going to be? Are you going to pay full price upfront, or what patients usually think is, well, if you don't know that much about the drug, then the price should be lower, and you can think about a price increase if the evidence shows that the drug actually does what it's claiming to do. So this is the consequence issue.
But the industry will always tell you they've always seen the price go down. They've never seen it go up. So,
so it's a trust issue on the one hand, and on the other hand, well, defunding a drug, if it doesn't work, it sounds fairly straightforward, but it's very difficult.
Can be difficult.
Because then you get into the issue of, are you going to pay just for hope?
Yeah. Well, that's the topic of today. Unfortunately, given that topic, we are, ladies and gentlemen, out of time. I do want to ask one final question, again, for both of you, if you could keep it short, 15 seconds or so. Anna, what one recommendation could you make to the use of adjuvant treatments, if you could right now? What one thing tangibly would you like to see?
If you're not reasonably certain that it's going to work, then try to get that drug into a clinical trial, either as a patient, as a payer, as a company, and ideally design this in a multi-stakeholder environment like MOCA.
Thank you. And Bettina, from your perspective, for the use of adjuvant treatments, what one key recommendation would you make from a patient's perspective?
And it touches actually on one of the questions that came in the end, whether early access programs would be of help. I do believe that what we need is proper data capture early on, and it's not an EAP because these products usually already have marketing authorization. But one of the issues I see with adjuvant in particular is that the final endpoint, overall survival, is not just affected by the first treatment, but any subsequent treatments that these patients will be getting once they move to adjuvant, unfortunately, to metastatic. So without proper data capture along the entire treatment pathway, we will never really truly measure what is important, and also never find out what type of sequencing might be optimal for the patient. So I do believe we have to get our systems set up in a way that we learn these things and faster, or as fast as possible, not to lose this valuable time. So I think just like I want pragmatism. It needs a systemic approach, and it has to be, I want to see a holistic long-term perspective, because as a patient, you don't care whether you get 1, 2, 3, or 5 treatments, well, provided you get them. It is the overall picture that counts. And I think our systems should move towards that.
That's fantastic. Bettina, Anna, thank you very much for your participation. From the audience who came in, thank you for your participation, and Merck Sharp & Dohme sponsorship. Thank you very much for your sponsorship of this series. And with that, this webinar is concluded. Thank you very much, and have a good morning, everybody.
Thank you, everyone.